Well, my name's Ramey. I'd like to start by just having a moment of gratitude with this talk. One of the goals of this talk is I work at the HJF Foundation up at the Center for Global Health Engagement. This department has been, kind of my home for a long time. I was reflecting on kind of, how much this department has kind of meant to me personally and I kind of thinking about through my whole career, I grew up in the Cold War. My dad was a Marine. We lived in Hawaii, and we used to do nuclear drills where we would get under our desks in elementary school. The Berlin Wall fell the fall of my senior year of high school. And I was already on my way to West Point expecting to learn how to, defend the fold the gap against the Russians or the Soviets. And little did I know that, my career and my life would be so different. Little did I know that a lot of the people that have been in this department would have such an impact on my life. So little did I know that 2 years later, a young, lieutenant or a cadet Chung would be reporting to my room every morning for the second semester of his plebe year because I was his team leader responsible for him. Little did I know that, as I went on and did my career that, I started here at USU in '98, and you think about what was happening in the '90s, we weren't really at war much. And then 9/11 happened when I was a fourth year medical student here, not knowing how much that would kind of change my trajectory. And then just thinking about people like Major Hemmer, Major Durning that helped train me when I was a resident and a medical student. I think recently retired Colonel Pangaro was the third year clerkship director at Walter Reed. The ability and the blessing of having a career surrounded by people of excellence, like, Dr. Waterman was a year behind me in residency, as well as her classmates like Andre Kapp, my own USU classmates, David Brett Major, Tim Quast, Drew Morgan, Josh Hartzell, Josh and I being residents together, really doing all 7 years of med school and residency together and seeing what an impact he's made to military medicine and now medicine in general. And so, and then running into classmates, downrange, and then just getting to come back and kind of finish my career here as faculty, and then now continue to be faculty and working to support our operational mission has been kind of just a real blessing. And so I really would just like to take a moment of gratitude. And if you were one of those people like, Dr. Morris that helped train me and Dr. McManigal, I think he was in the building. I saw him down the hall earlier today. So I just wanted to say thank you to all of you that invested in me, mentored me, and kind of sponsored me in different ways. The other thing I'd like to do is see if the slides work. I'll have to do old school. Today is the 18th anniversary. Today is of Sergeant Stevens' death. So Sergeant Stevens was a senior medic in my Bravo company during my first deployment. He was a college graduate who wanted to be a medic because his mom had died of a heart attack. And so he had been offered to go to officer candidate school, but he went to be a medic instead. He was, 28 years old, had kind of lived a little life, was older than my other medics, very mature, and the other medics kind of looked up to him. But on this day, 18 years ago, his vehicle hit an IED, and he was brought actually to me about 2 minutes later, where we tried to resuscitate him, and I eventually ended up pronouncing him dead. Which, I think is a really hard thing to do when you're a leader and a physician, knowing that he had a 3-month-old daughter that had been born, and so she'll graduate from high school this spring and go to college. And just thinking about how we prepare and provide medical care to our operational force is more than just what happens in that moment, but it has these echoes of implications for decades, and it affects people. And while, my life went on after that and that kind of stuff, his family's life was changed forever. And so I think that just calls, just to me, just really highlights the importance of the readiness that we need to have. And, oh yeah, this doesn't work. and how that really needs to inform the way that we look at problems and the urgency at which we start to attack and address them. And I think we're in a really interesting place right now in that there is a big pivot. And I think we actually are pivoting to the Pacific, and we've been trying to pivot our focus to the Pacific theater for the last 10 years. And, you know, things going on in Europe and the Middle East have continued to demand the military's attention. But time is kind of running out for us to really make sure that we're ready to go, and how medical readiness and preparedness contributes to that idea of strategic deterrence and demonstrates that we're ready to go. And hopefully that will, you know, keep it from being a fight in war. So, you know, I'd like to start with these questions. And those of you that have deployed before, some of those are probably familiar with to you. If you don't know what a PACE plan is, a PACE plan stands for, it's your contingency plan. You have one for everything when you're deployed. So you have one for your communications, and you have one for medical. It's kind of your pre-plan, kind of back plan B, plan C, and et cetera. And it stands for primary, alternate, contingency, and emergency. And it starts with this idea that the further down you go on your PACE plan, the more risk you're accepting. Because now you're doing something that maybe it's not what it's designed for, or maybe it's not fully up, or you're relying on something that is kind of ad hoc or tailor-made that isn't really as robust, hasn't been tested, or maybe it hasn't been exercised as much, right? And then ask the questions like, when you do deploy and you fall into an area, especially if you're going as like part of an advisor team, or you're going to an area to do a health engagement, you know, where do you get your information on where you're going? Where the local hospitals are? What are the capabilities of the local ambulance system? What's the number to call for the ambulance? Do they even come? Or is it like America was, you know, almost 50 years ago, where, you know, the only vehicles that could carry somebody supine were hearses? And so it would be the morticians that would come to the motor vehicle accidents, because there weren't really a lot of vehicles that would carry a patient on a stretcher. And then how do we know that we're leveraging all the capabilities for our wounded? How are we preparing for what I call the competition crisis gap? So we, you know, all of the combatant commands and their surgeons try to set the theater to enable and provide medical support for competition and our current baseline operations. But every once in a while, something happens somewhere where there's a casualty generating event, whether it's a disaster, whether it's an accident, whether it's a deliberate attack, where all of a sudden the needs that are needed to take care of those casualties are not in place because nobody was really expecting it. And there's going to be a time gap in place before the cavalry can arrive to either bring those medical resources there. And so what do those people on the ground, what do they have to rely on until everybody else gets there, right? Especially in a big Pacific or a big Africa, where it takes a long time to get places. And I think that's where the use of global health engagement, or GHE, is important, because we can use that as a tool to help understand and answer these questions. And I think it's also that idea that you know, some of these problems can't be solved out in the field. Some of them need to be addressed on the research lab. Some of them need to be looked at implementation science. Some of them need to be looked at systematically in terms of understanding what the gaps are, so that you know, maybe there's a solution to a problem, but that solution is single purpose and it's really heavy, and I'm not going to carry it in my rucksack, right? Because when you go out on patrols, a lot of times you carry your equipment, right? And kind of the mantra of the medics is everything that goes in that rucksack has to do at least two things, because I've got to carry it with me. And so if it does one thing really well, it must be that very risky thing for me to be willing to carry it. And so just understand, what are the issues that are that we need to support our own forces, but what are also those issues for our forces that are trying to work side by side with our host nation or our international partners that can need to be worked on at an academic center. And so the purpose of this talk in many ways is to help highlight those ideas and concepts that we're working on at CGHE. We're just having technical difficulty all over. What are the things that, you know, in terms of GHE that need to be addressed or can be addressed in an academic center to help inform those type of problems and the solution set that we can look to come alongside our warfighters and support them, right? So there's a lot of talk right now about, you know, increasing lethality in our military. You know, the medical role of that is how do we keep our forces healthy? How do we have a medically ready force from a force health protection and a readiness perspective, whether that be understanding the disease threats, having countermeasures, having the right equipment, having the right training, to also having a ready medical force, which is ready to take care for them, not only for trauma, but for non-battle injury and for non-communicable diseases, as well as you know, take care of those things that come up, right? Like I've had someone get pregnant like every deployment, right? But there's nothing in TC3 about pregnancy, diagnosing a pregnancy in a combat zone, right? So, and then how you manage it. But I think what I would say is you know, one of the key things that I think we're going to need to learn is that, you know, like the Rangers have their big five, you know, the things that they focus on, like, you know, physical fitness, small unit tactics, marksmanship, physical, communications, and medical. I think that we need to actually think about how we enable our forces to partner better with our partners, right? Because a big war like this, we're not going to be able to do it all by ourselves. And so working side by side with our partners, thinking about interoperability is going to be a bigger requirement than it has been in the past, because we're not always going to be the framework nation that's going to provide all the resources, not if it's a fight with a bunch of different nations in a bunch of different areas. And so I think we just need to be prepared for that. So if you're not familiar with the GHE, this is kind of the purpose of GHE. It's dictated by Department of Defense Instruction 2000 TAC 30, which is currently in the middle of a rewrite. So everything I'm saying may change in terms of the exact verbiage, but I think if you read the older version of the DoD, what you'll see is that it's really focused on interoperability, understanding the capabilities of our partners, and being prepared to fight a war, right? And that a lot of the health engagements that we did in Iraq and Afghanistan under the auspices of stability operations are not going to be what we're doing initially. Now, I think after a war, there's going to be another stability operation, so I don't think we need to throw all those lessons out in terms of helping our partners provide essential services and having a healthy environment. But really, a lot of focus is that definition of GHE, which is like building trust in our partners, having being the preferred partner, thinking about interoperability, and also how do we increase our readiness by making sure that our partners are ready and that we're exercising that readiness together so that we're delivering care together. And so what I would tell you is that, I'm sorry for this build, I thought I deleted it, is that, you know, knowledge management, I think, is the solution. Now, I will tell you, like when I was still in uniform, when people told me knowledge management, I kind of like got a little like defensive, because usually the knowledge management experience I had was some, you know, data scientist or KM person that basically was telling me I had to do something else with my papers and that kind of stuff, and didn't really demonstrate to me the value to me or my mission, other than maybe I could find something, but then I would do it and then the system would always kind of collapse. And so, but then when I actually got into studying knowledge management and the process behind it, what I realized is that as a military physician, I was actually doing knowledge management my entire career, which is trying to figure out how to be ready and how to, when my boss asked me a medical question, I was able to give him or her the best advice based upon all the information that potentially could be known about a problem. And that I've thought through all of those problems to the point where I've developed mitigating strategies so that when he says, hey doc, what can we do? I've got different options to put in front of them with pros and cons, and I'm able to give my commander a decision space. Because if the answer is we can't, or there's only one way to do it, that's not really a decision. That's just, and really our job is to give commanders decision space and to give them options so that they, and then communicate that in a way that in the language of risk, so that they can integrate that into their composite risk assessment, and they can think about the medical risk in association with the other risks. And so the goal here is, again, as it says up there, to get the information to the right person at the right time to make the best informed decision. But a lot of that is predicated on this idea of, understanding what knowledge management is, because, different people may not understand what the issues are, what's needed. And I'm not sure if I can move this. Sorry that that's covered for you. What do I do? In
the middle? Up here? Yeah. Okay. I'm afraid to touch anything because you did something with your slides. I could try to fix it so the view would be.
Okay, well, sorry about that. So the whole is creates the right conditions for innovation, right? And that's some of what I've done a lot of my career, which is, if you operate in the operating force, you kind of understand what the problems are. If you operate in an academic center, you may not understand what the real issues are. And so you need people and systems in place to identify what those gaps are, what the concerns are, and how you can move forward as a whole enterprise. And so that's what we're trying to do with our knowledge management system for the DoD GHE enterprise. And a good system involves all of these. It's not just a platform. It's just not a technology. It's not just a SharePoint drive, but it's focused on people and the requirements of the users, right? And so understanding that you're user focused at all the different levels of who's going to consume this information, who's going to be contributing the information, and how can we create a system in place where everyone can have their answers addressed in a way that's systematic and helpful, right? And so it requires these things like a culture of sharing and openness, especially if you have special knowledge and you feel that your knowledge, if you give it away or share it too much, that somehow that decreases your power. That's a common problem seen in knowledge management. And so trying to create a culture where sharing and enabling others is really seen as a vital goal as part of the whole project. And so this is a validated requirement for the DoD. It actually supports the .mil PDF change requirement, the DCR for GHE from the JROCM in 2019, which, if you're not familiar with that, that's the Joint Requirements Council at the Joint Staff that actually says this is something that we need. And it's what we would call a big R requirement that's been validated, but not just by the medical folks, but by the system in general, that says, yes, this is something that we need to continue to pursue. And so the whole idea for KM for the GHE enterprise is to provide value to the stakeholders, to mobilize knowledge, and to share it effectively. And so part of the goal of this discussion is to share with you some of the issues and the things that are going on, so that if you have something to contribute, that we'd like you to contribute, right? And so if you're, especially as we look at our university as kind of like a whole of university approach of how we're going to enable the operational force as well as our partnerships, I think that is going to be a role. And so, we need to look at every department within the School of Medicine and the other centers, as well as all of the other schools associated with the university, and see how can we leverage all of our expertise in a way to support the warfighter and make that something that we do as a university and not just individual efforts that maybe aren't as coordinated. And so just if you're not familiar with CGHE, it is one of the centers of the university. There are two centers that are not within the School of Medicine. One of them is CGHE. The other one is the National Center for Disaster Medicine and Public Health. Both of them have just recently been reorganized under the Vice President for External Affairs. And the idea is that both of those, especially with the National Center looking at the ICMOP which is the OCONUS Patient Movement Redistribution Plan. So if we get a bunch of patients coming back from the US, how we're going to use our national hospital system to take care of those patients because we don't have enough beds in just our military hospitals. Both of our centers are kind of externally focused, but we still have an internal focus in terms of teaching and training and education, both in the graduate school and in the undergraduate medical school and in the nursing school. So this is our vision. We're actually not that big of a center. I think right now we have about 20, 25 and a half. I'm the half because I work there half time and I work as a civilian hospitalist as my other half. These are some of our employees. I was working in my other job the day they took the picture, but it was established in 2016. It was actually right after I finished the GIM fellowship, and it evolved out of the Center for Disaster and Humanitarian Assistance Medicine, which initially was in the Department of Military and Emergency Medicine when Colonel Llewellyn started it, I think in 1999 when I was a medical student. That was focused on the disaster response, complex emergencies, working with humanitarian civil sector society to provide care to large health emergencies and large populations. And when the center was focused, when it was reset in 2016, the real focus was how do we support the U.S. warfighter, especially the Joint Staff Surgeon's Office and the combatant commands. And so we have these three main lines of efforts of training and education, research and scholarship, and operational support with cross-cutting responsibilities like knowledge management and let me see if I can get that to move. Anyways, management of like engagements, which is the chronic cross-cutting thing, which kind of goes into the operational support. Yes, ma'am. So the research comes from different locations. Some of ours is core funding that comes through the university. There's other funding that comes through specific projects. When CITM was initially started, it was all grant-based, based upon specific research projects. But as the center got into more operational support, there was core funding that came both from the Pentagon, from the Joint Staff Surgeon's Job, as well as through the university. And then specific money for grants, either from the combatant commands using their funds. And then, I mean, part of what we do as well is use other funds like ODACA funds or State Department funds if we can to leverage. A lot of it just depends on what the actual activity is. Does that make sense? Okay. And then, right now, I think there's only like 3 uniformed people in our center right now. We're about to get a lot more because DEMO, which is out in San Antonio, is coming to the university. It's still undecided exactly. If you're not familiar with DEMO, it's the Defense Institute of Medical Operations. They're actually a unit that's designed to go do training for international partners to teach them. And they've got a whole list of classes that they do as part of security cooperation. And so they're moving from San Antonio to here. Where they exactly are going to fall, right now they're under the Office of the Vice President for External Affairs, and whether it's going to be in our center or standalone or somewhere else, that's still to be determined. But they're going to bring, I think, 7 more uniformed personnel with them when they move here over the next 18 months. And so we'll have a little bit more footprint. This is our geographic scope in terms of actual direct and indirect support to the combatant commands around the world. And, when you look at what the requirements are, and, yesterday we just had a brainstorming session in terms of, what are how do we start thinking about how we can support the operational force in the next couple of years as our new SecDef and our new administration is focusing us more on the Pacific. You can look at the literature about recent ideas, which is, and some of these are from the Joint Trauma System and Mason, there's a student here where, the main key, one of the main points there is to optimize global health engagement in order to improve our readiness and our understanding of the environment. This came out from the Army recently where, the goal in many ways of the medical force initially is going to be to clear the battlefield and get those casualties out of the way of other operations because, taking care of medical folks in the theater kind of complicates movement and other resources. And so when we start thinking about a denied environment like the Pacific and a lot of water, thinking about patient evacuation, has to be thought of a lot differently, and not the way that we've been doing it for the last 20 years, which actually was a change from Desert Shield, Desert Storm, right? So Desert Shield, Desert Storm happened when I was a new cadet, like when I was doing my cadet basic training, and I found this old article a couple of years ago that talked about, I think there were 7 combat support hospitals on the same airfield at one point, right? So, and like not all of them, there was no coordinated plan, like how patients went to one, or the Air Force went to the Air Force hospital, the Navy went to the Navy hospital, the Army went to the Army hospital. And so, part of that, evolving, and the lessons learned out of Desert Shield, Desert Storm was the Joint Trauma Registry, and a lot of our effort to streamline and look at medical as a joint endeavor, and to try to be more lean and more cooperative. And so this is the way that I would propose that we think about global health engagement and what it can do. So, this model we developed thinking about global health engagement using kind of the framework of the global security agenda, which has now been suspended by our current administration. But I think that the ideas that they had there, which were mainly focused on infectious disease threats, but the idea of detect, prevent, and respond, I think are a really great framework to think about health engagement and the capability development that we need to do with our partners. And that, in order to go somewhere and know what the threats are and what the risks are, you have to know what the threats are. You have to have sensors out there, you have to collect, you have to do surveillance, but you have to send people there, you have to visit the hospitals, et cetera. Once you understand it, you can either mitigate the risks or just accept them, or you can prevent them, or then be prepared to respond. Just knowing that, especially if you're going to develop this with your partners, you can develop this kind of virtuous triad that, the more you know, the more you can prevent, the less you have to respond, the more you can get your partners to do all of those for themselves or in their area, the less we have to do it ourselves. And so that's kind of the idea, is that then, we don't have to do it, or if we do it, we can cover a larger area because we can work interoperably with our partners. And then you end up getting this, this virtuous triad like I talked about, but you're never going to prevent to zero. And so there's always going to be a response idea. Like we're probably never going to be to where we have 0 malaria cases of our deployed force around the world, right? It's a great idea, right? Okay, even smallpox, right? I would say, hopefully, right, especially with the big vaccine campaign we did a couple years ago, that we're kind of ready for that. But you still have to maintain at least some response capability. But then, if you don't need to do it for everybody, or if your partners can do it, then maybe you can do it together. The great example I like to think about this is like ECMO, which is high resource intensive medical clinical capability. And I read a proposal that was sent to the Joint Staff that said they wanted to put an ECMO team on with every squadron or something like that in the Air Force. And the guy at the Joint Staff is like, well, how is that going to work, right? But they're looking at the numbers of what might be needed in conflict. My thing is like, well, we've got a bunch of civilians that are doing ECMO, and we know the Canadians are doing ECMO, the French are doing ECMO, the Germans are, the Brits are. And so if we had a military consortium, and then we work together and they're all working kind of like the same clinical practice, then if we have a big event that requires a lot of ECMO, okay, now we just got to make sure, can they operate on our aircraft, or can we work on their aircraft, right? And thinking about patient movement and how we get them to the area, and how do we marshal, and those permissions and authorities that are going to be needed to actually do it together. And I think doing it together helps, and this is where global health engagement, I think the joint trauma system, and I think it's more than just trauma. I think it's like a global medical system that thinks about the medical challenges and the injuries and the illnesses that our service members face overseas, and how we're going to diagnose them, treat them, while still supporting potentially a kinetic fight, and how do we train our partners to not only take care of their own better, but also potentially be available to take care of us if needed. I think a great example of this is what was done in Ukraine by Special Operations Forces. This is a couple unclassified slides that were developed and briefed at the Special Operations Medical Association meeting last year. And so this was kind of a joint slide that started. You can see there's a 20-nation effort that started in 2014 after the annexation of Crimea that worked basically for about 8 years to try to prepare the rest of Ukraine for invasion. That included everything from establishing a special forces NCO academy to medical training. And so everything that's green in there had a medical aspect to their different lines of effort, right? And if you can look there, especially the remote advise and assist, and like we use these in Africa for our special ops, where the teams under my command or my boss's command, obviously, we're doing remote advise and assist using these special kits, but then the Ukrainians use them to do telemedicine as well, right? So they, how do we potentially leverage these type of capabilities together that enable them to where now they're in the fight. Okay, we're not in Ukraine fighting with them, but because we have this connection and they practiced using these remote advise and assist kits, they were actually using that to do telemedicine at the tactical level for things like, should I give this person blood? How do we prioritize this patient, et cetera, and kind of prolonged field care support. And these are some of the lessons learned from that. And so some of them you'll see are echoed in our knowledge management program, which is like the idea of telemedicine capabilities, contested logistics, and using the presidential directive authorities to release, give them a bunch of our stuff that we had in storage to kind of plus them up, as well as combining that with training, building the MedCop and AID Aries, which is a computer database system that basically was a laydown of hospitals in the area so that they knew where their hospitals were, the status of those hospitals at any one time. And then, the use of cold stored blood capability at the embassy in Kyiv, which could be used to, augment them on a humanitarian basis if needed. So these are the tasks I think are needed that can be done with GHE to medically prepare the operational environment. And so I would just encourage you to, take a look at these and maybe the research that you're doing or the work that you're doing, et cetera. I mean, there's a lot of work that's already being done, especially like in amputee care back in Ukraine right now. But just thinking about if we need it in our military, our partners probably need it in their military. And if you're not potentially already partnering with the researchers in those other countries that are thinking about this, in their country, then I would encourage you to maybe look at that as a way that you develop research interoperability with some of our partners so that, what's being developed can be shared kind of at the high end. And so this is our knowledge management program in terms of focus. I'm going to go through each of these and just try to really quickly, based on time, although I know we started late, just kind of let you know the kind of events so that if you want to participate, you can. If you want to sign up for training, you can. If you would like to listen into some of our community of practice for global health engagement, you're welcome to participate in that as well as contribute, or your students contribute. As you'll see, some of the, we get like calls at least every week, if not more, from like grad students and medical students here at the university saying they want to be involved with global health engagement. And they're looking for projects. And so we're a small center, like we've got ideas, but the whole university would be great if, we're also thinking about how the work that's done at every level is supporting this effort. And so from a research and thought leadership, I'll break that down into kind of 3 main levels. We do fund research called it's funded by the DoD through DHA Health Affairs that runs through us. We administer it every year. Which is the priorities that are set by the combatant commands. We also do research ourselves, a lot of qualitative studies looking at doing needs assessments or assessment monitoring and evaluation of programs that I cover under a different section, but that is considered part of our research. But then also like just academic inquiry. And so this project that we called Query, which is collecting, engagement-related issues so that when people come to us, we have a kind of a repository of questions or issues that have come to us from the field or those with experience that could be prompts for white papers or papers within classes or projects or capstones, et cetera. And then we do have, in terms of thought leadership, we've created what's called GHE snapshots, which are self-published little 1,000 to 1,500 word little thought pieces that we try to put out at least every month that help contribute to the community. And it could be anything. Like we had a medical student who'd been a Peace Corps volunteer. And as I sat down and talked to her, I'm like, so did you ever come across the military as a Peace Corps volunteer? She's like, oh yeah. I'm like, how did that go? And she's like, oh, it didn't go very well. I'm like, okay, what would you like the military to know about interacting with the Peace Corps, right? And so just thinking about, who's potentially going to be places. And then obviously we, submit stuff to the peer-reviewed literature and reports from the Joint Staff, et cetera. So this is Query itself. This is the QR code if you'd like to submit some ideas. On our Joint Staff page, we have the list of about 60 questions that are there now that we've organized by kind of topic, et cetera. Snapshots, like I said, are here. This is the 14th one, and most of them are on our website. And if not, just let me know. I can send you the links to some of the other ones. To put them on the website, that's public facing, as many of you know, can be painful. So we are building an internal Google site to put some of these things that don't necessarily have to be 508 compliant all the way to put them on the outward facing site. And so people within the university can have access to that and the ideas. In terms of operational support, we do run support GHE events, especially conferences for Indo-PACOM and some of the other combatant commands. We work with training partners. We help bring people to conferences to the university. Like we just had the German Surgeon General here, I think last week, and then we sponsored the Ukrainians coming to AMSIS a couple weeks ago. So international visitor support, especially like during Bushmaster, when we have international students and VIPs coming, we help support that, as well as GHE advocacy at strategic development meetings at the COCOMs, working groups, and networking in general. And then in training and education, we divide this into our formal education and then our community of practice. And so our community of practice is, we have a Mill Suite site, and then we also have what we call our peers, which are practitioner education exchange and resource sharing webinars. We just had ours on Wednesday this week, where we interviewed the commander and the chief of pathology at AFRAMS out in Thailand and talked about their health engagements in the region and working and the lessons they learned. And they actually shared some of the experiences from their earthquake in Myanmar and some of the impacts that had in Thailand. And then we also have this, what's your GHE story? We're trying to get people to tell us like, hey, what's your experience doing GHE, so that we can develop this kind of idea of like, okay, what'd you learn from that? What were the lessons learned? But how was that effective? How did that support the mission? And so if you're interested in submitting yours, please submit it. You can go to the website, but like Colonel Ball right there, she talked about, she gave an insight into partner capacity with the Philippine Military Vet Corps. She's one of the vets at AFRAMS. And so, we welcome people to contribute to that. And then, the other education part of it is, we run courses for fundamentals of global health engagement. There's a global health introduction to global health engagement that's on JKO that we've built. There is PMO 1037, which is done in the grad school on DoD GHE. So we support all of those, as well as residents from the preventive medicine rotating through, as well as medical students, as well as supporting Bushmaster, as well as during the military experience, like 2-week kind of mini sessions that some of the medical students do. In terms of the process focus is focused on AME, and these are some of the AME projects that we're doing now in support of U.S. forces in Southcom, especially the Air Force. The MUCH-MESH is military unique curriculum in Honduras and military emergency skills in Honduras, where teams from San Antonio are going down to the civilian hospital in Honduras and doing partner training with them, but also getting experience for their KSAs. And so trying to figure out how do we do the engagements like that not only give people experience with their engagement, but also see how other countries deliver care in their environments, right? And then getting some experience with them. And they go down with the staff, the residents go down with the staff physician who's supervising our residents. And then a GHE funding project. Those are some of the ideas at kind of the different levels of operation. And then in terms of interoperability, this is something myself and Dr. Shinkata are working on to develop a framework for thinking about global health thinking about interoperability, especially in austere environments where we may need to have expeditionary crisis standards of care in order to drive scope of practice, credentialing, and permission giving for interoperability in a way that we don't normally have. Because like right now, the only crisis standards of care and doctrine for the military is MASCAL, which is, then creates a whole ethical framework for that. But to me, I think not only is it important to think about how we work with partners from a quality and quantity perspective to mitigate risk to force and risk to mission, which is, mainly what our goal is in terms of making sure that the medical forces are in place, but also, the psychological protection of our healthcare providers by, having expeditionary crisis standards of care so that they know that we're putting them in a really crappy situation. So, we understand that things can be really tough, right? And then at the international, Captain Walton in Department of Surgery has been working internationally about military partnerships and civilian trauma internationally with this impact study, which has been kind of a multinational, multi-phase approach, and they're coming to the end of it, or she's working in collaboration with Harvard to do this at the international level. At the information focus, we have different programs. The big one being medical options, which is what kind of kicked off all of our knowledge management stuff, which I'll tell you about in just a second, but developing working with the Navy and the Army right now on developing a GHE tracker, a subject matter locator, so that we can find experts as well as knowing upcoming events. So medical options is, that's the acronym for medical options, but it's basically a repository of partner health capabilities. So what we found, and I saw this when I was the SOC Africa surgeon, is we needed a place where health assessments done by military uniformed personnel were collected because there was no place to put that information. It was just being lost, right? So when people go visit other hospitals as part of an exercise or as a pre-deployment site survey, or visit a clinic or do a health engagement inside a hospital, there was no place where all of that information was being consolidated. And so the idea is that initially came up to support MedCop, which if you don't know about MedCop, we'll talk about it later. But we've been waiting for more than 3 years now for our development sprint for our database to get brought into MedCop. And so we're kind of moving out ahead of it. And it's this idea of being a place where people can go to find out about the area. And we also have country pages that have documents about that people submit about that country. We did a needs assessment that drove kind of the requirements. We were able to publish some of those. And then this is our theory of change framework, where right now we're really on goal 1, which is just get all the information in one place. And then we'll work through the other goals, which include improve the quality of the data, kind of collate it together, inform decision-making, which is goal 4, and then share with our international partners and collate it. So on the slides, there's a link to medical options. If you have a CAT card, you can log on to medical options right now and look at the database. This is, we've recently just revamped it. So that's the link down there that if you go to Intel, it's under Intel Share on Intel Link, which is a .gov site. If you have a CAT card, you don't need to get a new password or anything like that. You can see we have all the combatant commands there. All of the health assessments that we get have metadata with their capabilities, and we're still populating some of that metadata. You have the ability to search it as well as look at it on a map to see where it is in relation to maybe where you're going to go. And you can drill down and you can change to like a terrain map, a road map, etc. There's also pages there for each of the combatant commands as well as country pages where, if there's any, like right now we post every ISOS medical capability report on the page so that anybody can access it who has a CAT card in the DoD. And we also break those down and we put them onto our map so that they can be geolocated. And so the way ahead for this is we're also building, it took us a while to get SIPR capability over at DHA. So we're building a similar one so that we can put documents above the level of COI on it. And because there are assessments that are done at the classified and secret level. And then working on how we can share that with our partners, hopefully getting it also into MedCop or one of the other data aggregators like C2IE, SOCIUM, which is the Security Cooperation Program, or MAVEN, which a lot of the combatant commands are using, which is the Palantir project. And then looking at interoperability standards, how we can share this with our partners, as well as how we potentially integrate AI into this to create bots, et cetera. So we did a pilot study with SoarTech, which is a technology company, looking at doing some pilots. And then right now we're working with Dr. Burke to build a RAG with our data so that we can actually develop a chat box here at the university to support medical options. And so you'd be able to go in there and ask questions that are informed by all of the assessments. So there's a lot of work that has to be done on that, but we're kind of excited about having that move forward. So and we appreciate Dr. Burke's willingness to engage with us on that. So these are kind of our focus. You know, these are some of the key slides. I'm happy for these slides to be sent out, so that, or at least the links. And you know, the idea is think of your own work. Like, what are you doing in terms of? I would encourage you to think about what's your knowledge management program. I would tell you that if you don't have a knowledge management program, you know, are you recreating things? Are you losing documents? But really, it's like you can't really be a learning organization unless you have a knowledge management plan. And so that's something that we've really enjoyed, like thinking about systems process and information requirements, who the users are. And so if you have questions about that, we're happy to share with you some of our best practices and the things that we've learned either at other centers. We've already been meeting with a couple centers to share what we've done and kind of move forward from there. So on behalf of Colonel Erickson, who's our director, as well as our other leadership, thank you for your time. I know.
So thank you, Dr. Wilson, and I apologize again for the technical difficulties today and for having to introduce yourself. As I was saying, I had a very touching tribute for my introduction today, but unfortunately, I had a chance to do it. So if I could ask a question. So I was talking to Dr. Jeremy Cannon, who's a trauma surgeon a couple weeks ago, retired Air Force. And he was talking about the concept of battlefield medical supremacy, which he defined as deliver the medical capabilities, equipment, supplies, and personnel necessary to save all combat wounded with potentially survivable injuries. In thinking about that, his point was we cannot cede medical supremacy just because we're doing LISCO. It's just not something we're just going to completely give up on. And in looking and in watching your talk, it's become clear to me that GHE is a critical piece of that. Right, so if we're talking about LISCO in the Pacific, all those blue countries there, like Japan, the Philippines, Australia, are a hell of a lot closer to where the fight's going to be than where we are here now. So my question to you is, and you kind of get at that potential end state a little bit. So my question to you though is, what are the biggest hurdles or biggest things that we need to overcome to get to that potential end state?
Yeah, that's a great question. It was actually one of the things that we talked about at our brainstorming meeting yesterday, and so. You know, if you think about where the friction is, I think where the real friction is right now is policy. And so an easy one to think about would be just like credentialing and the ability to like sponsor and have our partner physicians come and actually do medical care with us together in our hospitals, and for us to go do care with them in their hospitals. If you look at, if you're not a clinician, I can just tell you that the credentialing in the military is something that doesn't happen very fast, and it tends to be very risk averse. And so, and what we're talking about here is accepting a little bit of risk on the front side so that we're not having a bunch of dead service members when we go to war. And so, which is a different type of risk. And so I think that's one of the issues, and that's a discussion that's already been talked about. Some of that is a challenge on our end because the way that we do our medical licensing and our boards and our credentialing makes it hard we don't have a federal medical license. And so it's hard for us as a federal entity to, and you know, it's right now to practice medicine in the US, you've got to essentially have a medical license from a state. And right now, each state defines what that is, and it's based upon providing care in the US, not abroad. So that's some of the challenge, but I think another part of it is, you know, not everybody is I think that there's a certain attitude and personality that's good for health engagement and working with other countries, and that's not for everybody. And yet, we probably need everybody to have some baseline skills to just not, to not break glass when you go, not break a bunch of glass when you go meet a partner, but also, those people that have special aptitude for it, like, we don't really have a good method for talent management right now for people that really want to invest in this. So, I will tell you, the Air Force has led the way on this with the International Health Specialist Program. I was actually in Building A when General Carlton briefed in like 2000 about how the Air Force is going to have surgery in a backpack, and we're going to have these flying ICUs, and we're going to have these people that are trained to interact with the international health community. And I went up to him and said, "Hey, sir, like, that's great. Like, how do I do that?" He's like, "You picked the wrong service." Like, and I basically spent my entire career waiting for and preparing for the Army to actually have something like the IHS. And so, it hasn't come to fruition now. The Army now, the current Army Surgeon General, I think she really sees this as an enabler, kind of as you talk about, and how we, the answer was always civil affairs does it. But I worked with civil affairs, and civil affairs does a lot of things. They do some of this, but they're not experts in it. And so, and then there's the language barrier. I think, fortunately, most of our, so I just went to Vietnam and Japan 2 weeks ago, and, like, lots of English speakers in those countries. So, I think we have the advantage where a lot of those countries know that, if they're going to do business with the US, they've got to learn English. And so, but Google Translate came in like super handy in rural Japan where nobody really was speaking English. So technology can help overcome some of those things. And then we wrote a paper recently, I think, we don't have a system in place to actually make the most of these engagements. So we send people out to do global health engagements, and then they come back to the hospital, and there's usually no follow-up. There's no follow-on communication. We don't have systems in place. We don't have policy that carves out time for that person to maintain the relationships. And so, we talk as much, they talk even in the military how important relationships are, and yet we're not actually at the tactical care delivery level valuing those relationships that are formed when people go out and do their global health engagement. So we're just, we always send out somebody new, and there's not continuity, there's not follow-up, there's no development, unless you're at those higher level where you see the person every year at the conference.
So other than policy, strategic, and tactics, we got it.
That's right, yeah. Yeah, but at the end of the day, I think if medicine can't, if we can share intelligence with other countries, and we can share ammo, right? This was my argument about blood, when I was in South Africa, which is like, so, we can send the French our blood, and we can send them our intel, and we can send them our ammunition, but I can't get blood from them. Like, that doesn't, if we're really going to train as we fight, then we've got to get through some of these things. Now, I will say, and this is where I think crisis standards of care can be really helpful, having that framework, because a lot of countries can't go there, right? Like, a lot of countries that we train right now, the only people that can like start IVs are doctors and nurses. And so the idea of doing walking blood bank or a medic giving ketamine in accordance with the TC3, that's like, they're like, we can't do that. That's against the law. And so having those type of frameworks that would create the opportunity, if the conditions existed, that we could expand their scope of care if they're trained to do it, I think would be a little bit more palatable than just winging it. So I think we can do those type of engagements to set the conditions for better engagement.
I apologize. I think I took up all the time for questions. But Dr. Wilson, I want to thank you one more time for coming back here to your old home in the Department of Medicine and giving us a wonderful talk. Thank you.
Okay, thanks. Thank you.